Great. And then give me 1 second and I will launch Clubhouse and then we will go.
Different things that are happening, not just the differentiation of this pluripotent cell line, especially in the cardiac way. So that's where I found this really interesting, because if it considering they haven't done it in pigs yet, they haven't done a human trial yet, but I've read different variations of this paper before, and I thought that was just mind-blowing, actually.
Cool.
Thank you so much, Gayatri, and for that amazing article, and thank you for the amazing comments and discussion. I see that Dr. Yan has joined us. That means, I guess, our speaker is here.
Yeah.
Okay, so just to remind, all right, so as we move into our keynote lecture portion, the YouTube live stream will be actually pinned above, and you can see Dr. Segev's presentation in real time. If you have any questions regarding today's talk, you can back channel to our wonderful moderators on stage to get them in queue. And to Madhuri, Asta, Billy, Gayatri, Harshal, or myself as well, we will be turning off hand raising during the lecture. And if you're a known contributor to the conference moderators, please back channel us so that you can be invited onto the stage. And also your question can also be added in the queue. And now, with that being said, I would like to pass the mic to Dr. Yan.
Thank you. Hello and welcome. Welcome to MedNews Week conference, where we bring to you the most cutting-edge medical information with leading physicians in the field. I'm Jan Leifman, one of your co-hosts of MedNews Week conference. We are fortunate to have a great team to make these events a reality. Our chairs include Dr. Chandler Park, who's also the president of Kentucky ASCO, Pratusha Gahanta, who's also the associate director of MedNews Week, and myself. Our organizing committee is comprised of Lauren Vento, Alexandra Vendikayev, and Yavu Salai. Our educational committee includes Sean Jakewitz, Amaral Shimon, Pallavi Pai, and Melissa Mahanta. The managers of MedNews Week are Alexandra Vendikayev and Pratusha Gahanta. And the associate managers are Muskan Joshi, Billy Wilkerson, and Gayatri Menon. Our director of video production is Sean Jakewitz, and our media director is Pallavi Pai. And the moderator for today's event is Pratusha Gahanta. And now to introduce our amazing speaker. Today, we welcome Dr. Dorry Segev for a talk about COVID and the immunocompromised. As both a transplant surgeon and epidemiologist, he's an internationally recognized voice in healthcare disparities, healthcare policy, transplant medicine, surgery, and epidemiology. He's also currently the director of the Center for Surgical and Transplant Applied Research at NYU Langone Health. He's the vice chair for research in the Department of Surgery and is also a professor of surgery and of population health. Dr. Segev was the first to demonstrate poor immunogenicity to COVID-19 vaccines in the immunocompromised, work for which he was recognized by a letter of commendation from Dr. Anthony Fauci. He's also known for performing the first HIV to HIV transplant in the US and was also the first to demonstrate the survival benefit of incompatible kidney transplantation across the United States. As an avid researcher, including NIH funding, he has published over 750 peer-reviewed articles in journals, including the prestigious New England Journal of Medicine, the Journal of American College of Surgeons, JAMA Transplantation, and many, many more. Dr. Segev focuses on novel statistical and mathematical models for simulation of medical data, analysis of large healthcare data sets, and large multi-center innovative clinical trials and cohort studies. He's ranked number one worldwide in organ transplantation expertise and influence by Expertscape. He was recently elected into the National Academy of Medicine, a recipient of the prestigious Global Thinker Award for Foreign Policy magazine, and was also named an Innovator of the Year by Time magazine. But he's not only a leader in publishing research, but is also a pioneer in policy to help patients as well. This includes the HOPE Act, the HIV Organ Policy Equity Act, which enabled HIV patients on the current kidney and liver waiting list to be able to receive organs from donors with HIV. He also helped to write and pass the Charlie W. Norwood Living Organ Donation, which facilitated the development of the kidney pair donation program. Dr. Segev received his MD from Johns Hopkins University School of Medicine and his PhD in clinical investigation also at Johns Hopkins School of Public Health. He then pursued surgical residency at Johns Hopkins, where he then remained as faculty. While there, he founded the Epidemiology Research Group in organ transplantation at the Johns Hopkins School of Medicine that continues to leave a lasting legacy, with the group authoring more than 600 peer-reviewed articles. And so without further ado, it's my esteemed honor to welcome Dr. Segev. Thank you.
Thank you for your kind introduction, and it's really a pleasure and an honor to participate in this webinar to talk to you about COVID and the immunocompromised and paint for you the new normal for a subgroup of our population that numbers millions for whom the pandemic is not over. As you heard, I'm a transplant surgeon. I would say it's my day job, but it's also a night job sometimes. And I've done a lot of research in transplant policy and in immunology. But for me, the pandemic for the last 2.5 years has really been an interesting shift from somebody who takes care of people in the operating room and thinks about the diseases that impact transplant patients to really being the voice of the immunocompromised. And it's been kind of an honor to represent those who are immunocompromised. My transplant patients are immunocompromised, but there are many, many other people who have conditions that lower their immune system's ability to fight viruses, and their immune system ability to react to vaccines and to previous infection with long-lasting immunity. This has involved not just conducting scientific studies and taking care of patients in the way that many of us are used to, but has also involved writing a lot for the lay press and talking to a lot of journalists about how we can get the word out to the entire population. And you see here on this slide an opinion piece that I wrote for the New York Times a few months ago about Omicron and its impact on the immunocompromised. And prior to this pandemic, the last time I wrote for newspapers was when I wrote rock concert reviews for my college newspaper. I won't tell you what years that was, but it's also been a very interesting shift to get to communicate to the general population what it is that my patients and people like them go through. So this will be a story about the immunocompromised. But first, I think it's really important to think about what's happening today in the pandemic across the entire population so that you get a sense of the discrepancy between what most of us are experiencing and then what the immunocompromised population is experiencing. And when we talk about the immunocompromised, we're talking about in the US, for example, upwards of 11 million people in this country. So this isn't a very small group, but it is a very vulnerable group. So in the general population, and I'll say you and I, sort of addressing those who are immunocompetent with good immune systems, who can count on our immune systems to protect us. Most of us are either vaccinated or are convalescent, meaning we had COVID and we recovered from COVID. And actually, many of us are probably both had vaccines and then had some sort of breakthrough infection or another. We saw a ton of breakthroughs, even in the immunocompetent during the Omicron wave. However, that said, and we saw this in the Omicron wave, most people with this kind of immunity and intact immune systems are protected from severe disease. And we've heard time and again Omicron being referred to as the common cold or something like that. Most of us, if we got Omicron, or if we're looking, sort of at a potential Omicron infection today, we're not worried about being hospitalized on a ventilator in the same way as what we saw prior to the availability of vaccines, because we know that for the most part, we are protected. We are likely protected from severe disease. So for most people today, we're kind of back to the before COVID days. I live in New York City, as you can tell from my background, which is not what's currently happening in the city, but is the view from my window. And in New York, the restaurants are packed, the clubs are packed, Broadway is packed. People are walking around, eating, drinking in crowded spaces, dancing with no masks, and even vaccine confirmation has mostly waned. And this is our return to normal. Our new normal is pretty much normal. And so that's where the general population is, how the general population is seeing the current pandemic. There are issues. There are issues of variant escape. So we know, for example, that people who had protection from Delta and even who had Delta and vaccines were at risk of getting Omicron. So we're chasing these variants. With each new variant, there's going to be an escape of neutralization. So what I mean by that is, let's say BA6 comes out and you have whatever immunity you currently have. If you're exposed to BA6, you may not be able to neutralize BA6. So you might get BA6 and you might be at risk of spreading that to other people, but you probably won't get severe disease from BA6 because of the broad ability of your immune system and the T cell repertoire that you've built up and the memory B cells and all of this cross reactivity. They're highly likely to stop you from getting severe disease. So for the general population, variant escape is perceived as no big deal. There's also waning durability, and this is waning durability both to vaccination, and we heard this, those who are over 50 in this country are recommended to get 4th doses after their 3rd booster doses. And we know that after about 2 or 3 months, you lose neutralization from your vaccination. We also know that convalescent immunity, or what some people are calling natural immunity, also wanes, and you lose the natural immunity that you got from the Delta infection you had earlier, or an infection you might have had in 2020. So there is waning durability of our immunity. But again, for the general population, this is perceived as no big deal. There's also reduced caution in the world, right? I just described to you the situation in New York, which was not that situation a year plus ago. So we're no longer requiring masking. Most places aren't requiring testing. Some places aren't even requiring vaccination. There are crowded spaces of people who may be harboring this virus and the new variant. But again, it's perceived as no big deal because of the things we just talked about before. But is it really no big deal? Well, what does happen from this? If I'm immunocompetent, am I going to die because there's variant escape, waning durability, and reduced caution in the world? Probably not. But what's going to happen? What's going to happen is there are going to be more cases. We saw this in the Omicron wave. There were a ton of cases in the Omicron wave. The variant escape, the fact that we now can't neutralize the next variant, means that immunocompetent people will get it. People with normal immune systems will get it, will spread it, won't die from it, but there will be more cases. The waning immune durability means there will be more cases. The reduced caution means there will be inevitably more cases. Are more cases no big deal? Well, in the US today, we have about 100,000 new cases a day. And remember that the wave that scared the life out of us a couple of years ago was 60,000 new cases per day. So we have more than that wave that we were really, really, really afraid of a couple of years ago. And home testing belies this problem. So there are probably 200,000 or 300,000 new infections every day right now in the United States because of the new variants and the waning durability and the reduced caution and things like that. Because many of these home tests don't get reported to public health authorities because we don't have a really good way of following this and of reporting these and of those being counted, et cetera. So home testing is creating for us a false sense of security with regards to our case numbers. Just a few days ago, the New York Times ran a headline that said COVID cases surge, but deaths stay near lows. And they quoted the thing we've just been talking about, which is that most Americans now carry some immune protection, whether from vaccines, infection, or both. And we see this even with the CDC's focus. Remember, early on, the CDC was focused on reducing spread. So they would rank areas in terms of the risk of that area of spreading the virus. That changed completely. And now the CDC metrics are more like, what is the risk that hospital beds in this area will become saturated, that people will die, that there will be problems in the medical system because of some expansion of this virus. So we've all changed our focus from reducing spread to instead focusing on the fact that most immunocompetent people don't die from this infection. And as the New York Times said, most Americans carry some immune protection from vaccines, infection, or both. But guess who it is that doesn't carry nearly as much immune protection? It's the people that I take care of, the people that I've been a voice for the last couple of years during the pandemic, the immunocompromised, the millions of people living about you, your friends, family, loved ones, people you don't even realize are immunocompromised. For the immunocompromised, what does this mean? What does the current scenario mean? It means there's more virus around. The new variants are harder for everyone to neutralize, but especially harder for the immunocompromised to neutralize. And the immunocompromised, remember, have had a poor immune response both to the vaccine and to convalescent infection, which means somebody who's immunocompromised could have gotten Omicron, could have not mounted a good immune response to Omicron, and a month later could get Omicron again. And they have this poor immune response at a time where their immunity is even more needed because there's more virus around and the new variants are harder to neutralize. So for the immunocompromised, is this really no big deal? And I might argue that it is a big deal for this population. So that's where things stand today in terms of the pandemic and the role of the pandemic in the lives of those who are immunocompromised. And this is their sort of new frightening normal. Now, how do we know that the immunocompromised have a poor immune response? And this is where we begin our story for the evening. And I call this a story of a research study of 8,000 patients we never met. Because the fact that we're running research on people that we've never seen face to face is unique and is uniquely 2020 plus. We never ran research studies before this where we didn't interact with the participants of our research study. Why did we have to not meet the 8,000 people that were in our research study? Well, it's December 2020. And the SARS-CoV-2 vaccines have come out and are expected to be miraculous and game-changing for the general population. The general population, those with competent immune systems, are the ones who participated in the big clinical trials for Moderna, for Pfizer vaccine, et cetera, for the J&J vaccine. But the immunocompromised were purposefully excluded from these trials because the trials try to represent sort of the normative population and not the, they tried to represent the 350 million people in the US and not the 11 million who are immunocompromised. So we didn't even know if they were safe, let alone if they worked in the immunocompromised. Why would they not be safe? Well, imagine you're a transplant patient. You take medication to suppress your immune system so that you don't get a rejection. We give you a vaccine. What is a vaccine supposed to do? A vaccine is supposed to rev up your immune system. It's possible that by revving up your immune system to make antibodies against SARS-CoV-2, your immune system might also be revved up for alloimmunity, meaning to make antibodies against your transplanted organs. So there was no studies that told us if these were safe for the immunocompromised to use. And then also, when you're immunocompromised, it means you have a lower immune response. You need an immune response to make antibodies after vaccination. You need an immune response to broaden your T cell repertoire after vaccination, et cetera. So do these vaccines even work in the immunocompromised? And we didn't know. December 2020 in the US was the height of wave 3. This was a very scary wave. There were a lot of deaths associated with this. And if you were immunocompromised, it was dangerous to even leave the house, let alone leave the house, drive to a hospital, park in the parking lot, walk through the halls of the hospital to the research center, hang out in the research center with dozens of other people, wait in the research center to talk to a doctor or a nurse, wait there to get your blood drawn, come back a week later to do another interview, come back 2 weeks later to have your blood drawn, come back a month later to have your blood drawn, et cetera. That was too dangerous to do. So even if we wanted to use sort of our traditional research approach, we would not have been able to do so. It was also a prioritized rollout. So we didn't roll the vaccine out first to the immunocompromised. We rolled the vaccine out first to frontline workers, healthcare professionals, et cetera. And so if I were to do, for example, at that time I was at Johns Hopkins, and if I were to do a Hopkins study of the immunocompromised, December, I wouldn't have gotten very many immunocompromised patients. I would have only gotten healthcare workers, a few of whom are immunocompromised, but I wouldn't have been able to get enough patients to really make scientific conclusions. And I would have had to wait months and months and months before I accrued enough immunocompromised people in my study to get the word out. But we wanted to get the word out as early as we possibly can. And so we needed to reach out across the entire country in a novel way of recruiting people and engaging people with a research study. It was too fast and urgent for the standard, traditional NIH funding timeline. For example, typically at the NIH, I submit a grant in February, I get a score in June, I resubmit it in October, I get another score in February, a year later, and I see funding about 18 months after I applied for the funding. 18 months, we're in a completely different scenario. 18 weeks, we're in a completely different scenario. So even the accelerated funding timelines that were produced very rapidly by the NIH, many of them were still not fast enough to answer this question. We wanted to know within 4 weeks, were these safe in the immunocompromised, and did they work in the immunocompromised? Because the immunocompromised were already being offered these vaccines. It was also too fast and urgent for a standard research approach. A standard research approach would mean that I invite, let's say I get 5 hospitals together. We invite all of our immunocompromised people to participate. All 5 hospitals need to get IRB approval, and then they need to get data use agreements across the entire 5 hospitals, which can take weeks to months to put together. And then we need to enroll people in person, and then we need to put them through the whole study, et cetera. Too urgent for that kind of approach. And I would have needed like 50 hospitals to work together to get enough patients to make early conclusions about this. We ran a study that we promoted over social media that in the first week of enrollment, we had over 1,000 patients enroll in the study. So we had a high volume study that required multiple visits for symptom reporting, reactogenicity reporting, et cetera, and multiple blood draws to look at the immune system response to this. I will tell you that this entire study that I'm presenting to you was funded by one philanthropic donor that had the vision to do this. And without that donation, there's no way we would have gotten the funding that we needed to make this happen. And it was all done using a totally novel technology-based approach. So what I call research in the 2020s. This is an example of what I'm talking about. So this is the TAP2 capillary blood collection device. We can send 5 of these to somebody's home with an instructional video on how to use it. This is one of our research assistants demonstrating that you take it, you stick it to your arm, you push the plunger, you feel nothing when you push the plunger. It pushes like a couple of dozen microneedles into your skin. You don't feel those things. It draws out some blood by capillary reaction. It fills 200 microliters into that tube. You take the tube, you cap it, you pull this thing off your arm. You just generally don't even see any blood dripping from there, but you can dab it and it's done. You put the tube in the mail. You send that tube to us. We can study what your immune response was to the vaccine, which is huge. By January, so December, the vaccines came out. By January, we already had safety data, which was published in a journal a couple of weeks after that. So by February 4th, so less than 2 months after the vaccines came out, we already had safety data. By April, we had safety data on 2 doses in hundreds and hundreds of transplant patients. We also had it. So I'm going to give you the data from the transplant patients, but there were also parallel studies we were running in the autoimmune disease population, in the oncology population, in other immunocompromised populations. We determined that it was safe for transplant patients and other immunocompromised people to get these vaccines, and that the reactogenicity was no different than that in the general population, maybe even less reactive, and that there was no signal to indicate that it was harming, for example, the transplanted organ, etc. However, by March, we already had data. This is what we called the Houston We Have a Problem publication in JAMA. We already had data published in JAMA in mid-March that the immune response of those immunocompromised patients, and again, this is from transplant data, was substantially suboptimal compared to that of the general population. So 100% of trial participants had a lot of detectable anti-SARS-CoV-2 antibody, even after 1 dose of an mRNA vaccine. Antibody was only detectable in about 17% of transplant patients. When we extended this to 2 doses and we looked at the antibody levels, it was pretty clear that for the overwhelming majority of transplant patients, they did not reach antibody levels comparable to that of the general population. This was quite similar in other immunocompromised populations, and it made us worry about their ability to be protected from COVID infection. Now, did antibody levels correlate with neutralization, which is the ability to stop the virus in its tracks? And did that correlate with clinical protection? Well, we got some of the data from transplant patients that I'll talk to you about in a second. A lot of the data came from the Moderna trial, the 30,000 patients that participated in the Moderna trial. They measured antibody levels, they measured neutralization, and they looked at clinical protection, which means what was the risk of getting a breakthrough infection in somebody who was fully vaccinated. And they showed that as these antibody levels increased, so did neutralization. And as neutralization increased, so did clinical protection. So every 0 you added to the antibody level meant 40 to 70% less risk of a clinically relevant COVID infection compared to those who had lower antibodies. So we knew that by studying antibody levels, we were studying a good surrogate for whether somebody was actually protected or not. When I say poor immune response, what do I mean? We did a study on 18,000 transplant patients who were all fully vaccinated with 2 doses of an mRNA vaccine. And we compared them to the general population who was fully vaccinated with 2 doses of an mRNA vaccine. And we looked at risk of a breakthrough infection, meaning a COVID infection that occurred in somebody who was fully vaccinated. And we looked at the risk of a breakthrough infection with associated hospitalization, or death. If I leave you with nothing else today, I want you to appreciate the magnitude of risk that the immunocompromised were taking in this pandemic. And this is why I say the pandemic is not over yet for the immunocompromised. They had an 82 times higher risk of a breakthrough infection and a 485 times higher risk of a breakthrough infection with associated hospitalization or death. For those who read the medical literature, if we find 2 times higher risk of something, we all freak out. Like, oh my God, this is twice the risk in those who have this gene versus that gene. We totally freak out. That's a major discovery in healthcare. But these patients had a 485 times risk, not a 2 times risk, but a 485 times higher risk of a breakthrough infection with hospitalization or death. When I talked to The Atlantic about this, I gave them this quote, which I'm going to read to you because it's really important. Imagine walking around and being in society and thinking, if you give me COVID, I might have a 10% chance of dying. That's not good. That is frightening. And that's what I mean by the frighteningly new normal. Now, does this only impact the immunocompromised? No, this is both an issue for the immunocompromised individual, but is also a public health issue. Here's the deal. Here's what happens. Somebody who's immunocompromised can't mount a good immune response. So they get infected with SARS-CoV-2. They have COVID-19. The COVID-19 kind of wanes, but the SARS-CoV-2 doesn't disappear because they can't neutralize it at all. It stays with them for months. As it replicates, it becomes mutated. A new variant is formed. One of those new variants will spread to other people and will be one of those strong, robust new variants. And there we have a new variant in the population. So the fact that there are immunocompromised people, if we don't protect them and we don't do the things we need to do to make sure that they don't get COVID, we are risking the public health of the entire nation, the entire world, by creating new variants from those who are persistently positive. So I tell people, even from the most selfish perspective of the pandemic, as somebody with a perfectly good immune system who thinks all of this stuff is NBD, there are persistently positive patients from among the immunocompromised who make this not NBD. Fortunately, people were listening. Dr. Fauci was listening. He was presenting our findings at the White House briefings. And it became very clear that 2 doses of vaccines were not adequate for the immunocompromised. So we tried to get policies changed. Patients and the advocates tried to get policies changed to allow additional doses. But the problem was that there was not funding available at the time to test these third doses. And the way the system works, you need approvals from this and approvals from that, approvals from the FDA, et cetera, to even test these things. And what ended up happening in the United States is a group of immunocompromised people said, enough is enough. We are getting ourselves third doses. And in one of the greatest ironies of vaccine policy in the United States during the pandemic, those people who went and got themselves third doses by going to pharmacies and not telling them about their first 2 doses or somehow navigating the healthcare system, we were able to study their response to the third doses. And the data that came from these people who kind of broke policies by going to get their third doses became the data that were presented to the CDC and the FDA that caused the CDC and the FDA to authorize third doses for those who were immunocompromised. So the third doses became available for the overwhelming majority of the immunocompromised after a brave minority of the immunocompromised went and took matters into their own hands and showed that this is actually an effective way for somebody to get better immunity. So these were approved for a whole slew of categories of people who were severely immunocompromised. And as I said, I've shown you data from the transplant population, but this also includes those oncology patients, those with primary immunodeficiencies, those who take immunosuppression for other immune conditions, those with autoimmune rheumatic diseases, et cetera, et cetera. These third doses became available, but even then, we had a lot more people. So you're looking at a study of those who got the third doses, and you're looking at their antibody levels before and their antibody levels after. And a lot of them had a really nice boost in their antibodies with that third dose, but still some of them remained far at risk because they had very, very little improvement with that third dose. And what we've been doing since this approval came from the FDA and CDC is to try to figure out how we can get all immunocompromised patients as protected as they possibly can be. And I'll show you a little bit of the more modern data. One of the things we've talked about during this pandemic, especially during the vaccine era of this pandemic, is heterologous immunity. And what we mean by that is you get a vaccine of one platform, and then you switch platforms to another platform, and you assume that they're going to work on your immune system in slightly different but complementary ways, and you might see a better immune response. And what we showed just a couple of months ago was that heterologous third dose strategies in transplant patients seemed to outperform homologous third dose strategies in transplant patients. Now, I'll say this is not a randomized trial. There's so much, there are limitations to what we can infer from these findings, but they do hint to us that perhaps the standard, you must stick with the same platform, you must have homologous immunity approaches, is not necessarily the way we want to go about doing things. And we're trying to learn more about that. We're also trying to learn what happens if we change somebody's immunosuppression at the time that they get these additional doses. Does that help them mount a better immune response? Ultimately, there will be some people who just can't, with their own what we call active immunity strategies, their own immune system just can't make enough antibodies to give them protection or to give them adequate protection. And then there are the monoclonal antibodies. So the monoclonal antibodies became very popular pre-vaccine as early treatment. So people who got an infection that was detected early, as they started to deteriorate, before they really started to deteriorate, we hit them with monoclonal antibodies, and that gave their immune system basically a million little soldiers to go in and get the job done. What we can do now is give people monoclonal antibodies even before they're exposed, because we have longer acting monoclonal antibodies. And so here you're looking at some data from the pre-exposure monoclonal antibodies available in the United States and how they impacted transplant patients. And when we gave these to when transplant patients received these monoclonal antibodies, even with maximum vaccination that they got, their anti-SARS antibody levels were in the 400 range, and they jumped to the 3,400 range, almost a 10-fold jump in antibody levels after receiving these pre-exposure monoclonals. And this was not just associated with an increase in circulating antibody, but also an increase in neutralization. There was good neutralization to sort of the ancestral variant, but we don't see the ancestral variant. There was actually not such great neutralization to BA1. Neutralization basically started at 8% and ended at 16%, and that wasn't very, very good. But fortunately, we don't see BA1 very much anymore, and mostly what we see is BA2 or the newer variants since then. And again, neutralization increased from 7%. And bear in mind, this is among vaccinated transplant patients, only at 7% neutralization to BA2 after receiving these pre-exposure monoclonals. Now 72% of them showed neutralization to BA2. So high likelihood that they were improving their clinical protection. So for the immunocompromised, what we've learned is that they need more vaccine doses than the immunocompetent. We might need to change immunosuppression on them. We're right now running a big NIH-funded randomized trial to try to answer this question. They are likely to benefit from pre-exposure monoclonal antibodies, as I just showed you, and those we continue to study as the variants evolve and we continue to chase these variants. For the immunocompromised, ring immunity is critical, and what we mean by that is basically immunizing your whole bubble. So if you live with people and you're immunocompromised, they should do everything in their power to get vaccinated and make sure that they stay up to date on their vaccines so that they provide a more sheltering environment for the person who's immunocompromised. And then the immunocompromised today continue precautions. If mask mandates are lifted and you see people in a movie theater wearing masks, they probably are immunocompromised. They probably know that you don't necessarily care if you get Omicron because you're probably going to be fine. They may not be fine. And in fact, there's a fairly good chance that they're not going to be fine. And there's a fairly good chance that they don't have a whole lot of protection. So if they are leaving their house, which, we all kind of need to do at some point, they're going to need to continue these sort of pre-vaccine precautions that we all were a lot more adherent to prior to our now more reassuring state of immune protection. So what did we learn from a research study of 8,000 patients we never met? Well, I just told you what we learned about the immunocompromised and vaccine immunity, but we also learned that we can study 8,000 patients over technology, over the internet, using mostly non-human interactive forms. We can draw their blood. This means we can run all sorts of really important research studies at the drop of a hat if we do it right. So after all of the work that we did, we had another idea a few months ago. We launched this study online. We filled our study with more than 2,000 patients in less than 24 hours. And 1 month after we conceived the study, it was already published in JAMA. So we went in from 1 month from conception to publication of this study. This kind of stuff would never have been able to happen prior to 2020. So we've learned that we can do really fast research studies that are ethical and that are safer for people to participate in than our more traditional research approaches. But also it has huge implications for how we might practice medicine. So imagine that I'm taking care of somebody and they're in a window, they have a chronic disease, but they're in a window where they're at higher risk than they might normally be. Ideally, I'd like to sort of invite them into my house and keep an eye on them and round them every day, maybe, round on them every day, maybe admit them to the hospital or something. But we can't do that every time we think somebody might get in trouble with their disease. But we could potentially get their blood drawn every other day or every week during these periods where we know that they're at higher risk. And we don't have to make them come into the hospital or go into, one of the commercial labs. We can just send them the gizmos, have them draw their own blood, mail them back to us, and we can monitor them in real time. So we've also learned that we can take care of patients without the traditional model of how we normally take care of our patients. And so I'm going to end things here with the hopes that we'll have a really nice Q&A discussion. And I'm going to say that in addition to lessons from a research study of 8,000 patients we never met, I really want to give thanks to 8,000 research partners we never met, because really the people who participated in this study, they were as innovative and as ahead of the curve as those of us who were running the study. And as I told you, as that example, some of these people were so progressive that they changed medical care in this country before even the CDC or the FDA changed medical care. And actually, the CDC and FDA followed them in their footsteps rather than leading what was happening in terms of care for our immunocompromised friends. So I'm going to call them research partners, and I'm going to end the didactic part by giving thanks to all of them, and thank you to you for your attention.
Thank you, Dr. Segev. That was such an amazing lecture. My name is Pratyusha. I'm the moderator over here at Clubhouse, and we have a huge line of questions ready for you, and we are really excited to get started with the Q&A portion. Just a reminder to the audience member, feel free to submit your questions through the back channel to our lovely moderators, and we will get them in queue. So for the first question, I'm going to pass the mic to Dr. Yan.
Thank you so much for that wonderful presentation. So given the research examples that you gave, how do you feel this potentially new Quicken research approach will change the future of clinical research and potentially clinical trials moving forward? Thank you.
Yeah, so there have been some operational changes that are very tangible, right? For example, before the pandemic started, it was very hard to get an IRB to approve an electronic consent form. We used to, even as recently as a few years ago, have to send a paper consent to the patient, even if they weren't coming in person, go through that consent with them over the phone, have them sign the consent and send it back. And that was considered progressive. Usually we had to make them come into the hospital and have a one-on-one in-person conversation about this. What we've learned is we can have them sign this electronically. We don't need to do this on paper. We don't need that for them to come into the hospital. We can do all of this stuff remotely. We also learned, in healthcare, we learned that we can interact with patients by telemedicine. Now we're adding a dimension of that where we're learning that we can draw people's blood without forcing them to come to the hospital, without sending a phlebotomist to their house, without forcing them to come to a blood drawing lab, et cetera. So we can do blood tests on people without them having to leave the house either. And so I think the more we learn from this, the more we realize that the traditional model of come in, interact with your medical team, they do the things you need to do, and then go home can be changed completely. And a lot of this stuff can be done from home. And I hope that payers will catch up with this and hospital systems will catch up with this. And our ability to seek medical care will become a lot more streamlined and convenient.
Thank you so much for that wonderful answer. I hope our medical system does get streamlined and it does get more efficient. So I will be asking the next question. My question to you, Dr. Segev, is what is your opinion regarding the measures taken and currently being taken to decrease the spreading of this virus? And as a follow-up, do you think it is enough, or do other precautions need to be taken into consideration, especially thinking of the immunocompromised population? Thank you.
Yeah, so I would say, unfortunately, there aren't measures being taken to reduce the spread of this virus. I think our society has given up on this. We are no longer focused on reducing spread. In fact, all of the things that I showed you about the current state of the pandemic are increasing cases. Cases are going up. We still have a ton of new cases. We are not, as a society, trying to reduce spread. What we're trying to do as a society, and I'm not going to say that this is the right thing, but what we are trying to do as a society is to reduce hospitalization and deaths and severe disease. That is all fine and good if everyone is immunocompetent, but not everyone is immunocompetent. And so the immunocompromised are still at risk. They're still suffering. They're still having mental health issues because they can't leave the house and go to a crowded restaurant, and a crowded theater, and a crowded bar, and a crowded wherever it is festival that they want to go to, because they know that they are at risk for catching the virus that is, sort of floating around the air at those events. I think the immunocompromised today are kind of forced to take matters into their own hands, try to find pre-exposure monoclonal antibodies if they're eligible for them, get as many vaccine doses as they possibly are allowed to get through the current recommendations, work with their doctors to try to, if possible, modify their immunosuppression when they get vaccinated, hope that they have some sort of T-cell repertoire to give them a modicum of protection. But for the most part, today, in the things that I do and feel comfortable with without a mask, feel comfortable doing without a mask, the immunocompromised are not going to feel that way, and they're going to need to wear a mask to do those things.
Thank you so much for that wonderful answer. And I do hope that things do get better for the immunocompromised population in the future. And I will pass the mic to Madhuri for the next question.
Thank you so much, Doctor, for this wonderful presentation. I really learned a lot about what's happening today with immunocompromised and COVID vaccinations. So my question is, now that we know what exactly is a vaccine's durability, with the multiple strains coming up and the different booster shots that are there, what is your definition or concept of being fully vaccinated?
Yeah, it's a great question. I think being fully vaccinated today means being up to date with whatever the recommendations for vaccination are that take into account durability. So 2 shots is not up to date anymore, right? If you had 2 shots in 2021, your durability is waned and you need a booster. And even if you had a booster a year ago, you probably need another booster now, unless you had Omicron a month or 2 ago, et cetera. I have written a lot about the possibility that we use antibody level measuring to give people more data about whether they have a reasonable amount of immunity or not. I have recommended this to the entire transplant population. I think people who are variably immunocompromised and really don't know at what level of protection they have will benefit from checking their antibody levels to knowing it. I think if you're part of the general population, the CDC and FDA guidelines for the general population cover the general population, and you would be able to consider yourself fully vaccinated. Does that mean you have neutralizing immunity to the new variants that come out? Probably not. Maybe, but it certainly doesn't give you a guarantee of neutralization to the new variants. There are, in addition to durability boosters, there are also being developed variant-specific new vaccines. So kind of like the old vaccine, but now instead of going against sort of this ancestral variant, they're now going against the new Omicron variants. Are the vaccines going to be able to keep up as quickly as the virus is mutating? No, but can we make a vaccine to Omicron that covers a lot of these BA variants? Probably. Will that be more helpful than getting another booster of the ancestral vaccine? Sure, but we have to get those things out there. And one of the things that needs to happen is the FDA needs to be a lot more rapid about approving variant-specific vaccines with using platforms that have already been authorized for the original ancestral variant, rather than requiring another year-long randomized trial, which will then slow down all of the efforts.
Thank you so much, Dr. Segev, for that wonderful answer. And now I'll be passing the mic to Asta for the next question.
It was a really wonderful session, Dr. Segev. And my question is, do you think the risk of development of long COVID is all related to viral load? What about cytokine storm? What is the pathogenesis of this?
Yeah, I think sadly, long COVID is something we don't have a great understanding of, and we might not for a while. And with all of these evolving variants, we might not ever really have a very good sense of long COVID, what it comes from, what it means, what the implications are, et cetera. There are some theories that there is a higher risk of long COVID from the older variants. And the reason for that, the theory is that the reason for that is that with the older variants, people got higher viral loads, and pre-vaccines, people had worse courses of Delta than they did of Omicron and things like that. But this is not perfectly well known right now. There aren't great data to be able to make inferences.
Thank you so much, Dr. Segev. And I will be passing the mic to Gayatri for the next question.
Dr. Segev, I really enjoyed your talk and I learned a lot. Doctor, I had two questions. So my first question is, in patients and kidney transplant recipients who've been previously infected with COVID-19 compared to people who haven't been infected but have been vaccinated, there's definitely a difference in anti-spike IgG titers. So, but this could be attributed to a higher antigen dose with infection rather than with vaccination. So I was wondering, like, we've established that 2 mRNA vaccination doses are fine, now 3, and now recently even 4 is okay. So how much is too much, and can we consider repeated doses of vaccination together? Is that okay? And just quickly adding on to that, in patients with chronic kidney disease or end-stage kidney disease, with medications like rituximab or with mycophenolate mofetil, so they have a reduced response to the COVID-19 vaccine. So how do we combat this, and what other standard treatments can we consider in these patients?
Yeah, so you bring up an interesting point. Transplant patients who are convalescent have in general better immunogenicity than those who were vaccinated. Why is it that they get better immune responses from previous infection than vaccination? One reason might be, as you suggested, that they see a higher antigen load for a prolonged period of time. There is another reason, though, that I suspect strongly that is proving more and more true as we gather more data. When a transplant patient gets COVID, as their healthcare provider, what would your natural inclination be? Your natural inclination would probably be to reduce their immunosuppression. And in general, that's what happens. If our transplant patients get COVID, the first thing we do is we stop the mycophenolate so that their COVID infection is not as severe. Well, when we stop the mycophenolate, we actually stop the agent that is most responsible for blocking the immune response to the vaccines. And so they're seeing a higher antigen load, they're seeing it for a longer period of time, and they're seeing it at a time where we've actually reduced their immunosuppression. And I think it's that last thing that's really causing them to be more immunogenic. So what's the answer then? Do we give them 4, 5, 6 doses? Well, we find that there is a point of limited return for these patients. So sure, those who didn't have a good response to 2, a lot of them get a good response to 3. Of the few who didn't have a good response to 3, some have a good response to 4. Of the few who didn't have a good response to 4, fewer of them will have a good response to 5. So just doing more and more and more of the same is going to plateau in our ability to get sort of efficacy from this approach. I think what we need is, and we are now studying this in a randomized trial, is we need to think, well, for those in whom just additional doses are insufficient, maybe what we need to do is turn them more into the immunosuppression phenotype of the person who had a convalescent infection, meaning should we hold the MMF during the time of their additional vaccine shots? Should we time their vaccine shots so that it's as far away as possible from their anti-CD20 antibody rituximab treatment that they had, et cetera? And that's a thing that we're learning right now.
Thank you so much, Dr. Segev, for that wonderful, wonderful answer. And next, I'll be passing the mic to Mike.
Thank you very much. I'd like to take a quick minute to just introduce myself to your panel. My name is Mike Nelson. I am a double lung transplant recipient and immune compromised, and I have a couple of questions I'd like to ask of the doctor. I'm 2 years out. I had my lung transplant at the height of COVID on the 21st of March in 2020. So what I wanted to say is, first of all, I'd like to thank the doctor for his research. And I was not a part of any research team. I would love to be, but I have not been approached. Also, I learned some interesting things from you tonight, and I would like to know how necessary or how often should I be getting tested for the antibodies? I have had 6 shots now. I've had the initial 2, the 2 boosters, and then the 2 series injections of EvuShield. I have had 0 side effects from any of the vaccines, to include even localized itching or swelling. Absolutely nothing. I live in fear. I do not leave my house without a mask. I leave my house to go to the doctor and back home, and that's it. So I guess my questions are, first, how can I get involved in one of these research studies? And secondly, do I need a prescription? How do I go about getting my antibody test? Because I believe my transplant team, that's not something they're following, to my knowledge.
Great. Well, first of all, thank you for participating in this. And I'm really glad that we have transplant patients and other immunocompromised people listening to this and learning. And I'm glad that you were able to get exposed to some of the data that we have. And I'm also very glad to hear from you and to hear your experience. And those on the other side of the doctor-patient relationship, meaning those who provide medical care to people like yourself, I'm glad that they are able to hear directly from you what it really feels like to be going through all of this. I'm also glad that you've managed to stay protected from the virus, which is a tribute to your adherence to very careful behavior and things like that. And I hope that with our conversation today and with conversations with your medical team, and you are welcome to connect them to me. I'm very happy to talk to your medical team. It's very easy for people to find me online. I can assure you of that because I get hundreds of emails a week with people asking questions and people's doctors asking questions. I'm hoping that we'll be able to find a way for you to get back a little bit more of your life, so that you can kind of live more fully, because I know that it's very depressing to not do so. So with regards to antibody testing, there are widely available commercial labs that do antibody testing. The ones we use in our study are through LabCorp. If you go to the LabCorp website, you can even order an antibody test yourself, and you can go and you can get the antibody test and they'll bill your insurance, or you pay a few bucks out of pocket and you can get the thing done. I personally get mine done every 2 months just so that I know where I currently stand with things, but also because I'm a researcher and I'm inquisitive and I just want to know these things. I will tell you, I cannot obviously provide medical advice over the phone, by webinar, et cetera, but I can give you some really important information that you can then discuss with your medical team. We have written in the American Journal of Transplantation that we strongly recommend for all transplant patients to get their antibody levels checked so that they know where they stand in terms of their ability to be protected. Now, this recommendation came out basically after vaccines, but before the wide distribution of EvuShield or pre-exposure monoclonal antibodies. We don't fully know what an antibody level means when you get it after Evusheld, although our current study, and I referred to it in this talk, shows a correlation between measured antibody levels and neutralization. So we think that if your antibody levels are very high, you probably have neutralization that resulted from the Evusheld, and if they're not very high, you probably don't have neutralization. Now, how do I define those things? You can look through the paper and see the data. They're not that clear. It's really hard to tell you if the level is higher than 5,000, you're fine. And if it's lower than 5,000, you're not fine. Nothing is binary here, but I would strongly encourage you to talk to your medical team, show them the article that we wrote. It's available for free online about our recommendation for transplant patients to be antibody tested. Show them the op-ed that we wrote in the New York Times. I think they also made that free, so it's not sitting behind a paywall. If it is, email me. I'll send you the text from the article. And feel free to have your medical team contact me, and I can give them as much advice or as much insights as I possibly can so that they can then discuss to you the advice to give you. I would say that, you know, if your goal is to never, ever, ever get COVID, then it's hard to justify leaving the house, you know. The safest, let me put it this way, the safest thing obviously for anybody to do is to stay at home and not leave the house and to work from home, etc. But that is not the ideal situation, and that obviously wears down substantially on a lot of people's mental health. And if you are somebody who would like to go out and would like to live life, I would discuss this with your doctors. I would get your antibody levels checked. I would talk to your doctors in light of that information and in light of the information that I gave you about BA2 neutralization that we published in transplant patients who got Evusheld. And, you know, I'll remind you that, so, you know, one of the things that I do as a hobby is I do rock climbing, and rock climbing is an inherently dangerous sport. And that's a phrase that we use on every waiver for every rock climbing gym I've ever participated in. Yet I still do this, and yet I'm still willing to do this. So we all have different risk thresholds. And I think it's really important to discuss with your medical team where your risk threshold is today and how you would like to be managed so that you can live the life you want to live within the risk threshold that feels most comfortable for you.
Thank you very much. That's all I had. I appreciate it. And I've gained a great amount of information this evening. Thank you.
Great.
Thank you so much, Dr. Segev, for that wonderful answer. We have so many questions. However, we're running out of time, and we will end with our last question. And our last question will be asked by Harshal. Passing the mic on to you.
Thank you, doctor, for this super insightful session. So my question is of the topic related to your life journey. So I'm really inspired by your career in surgery. So for our younger attendees just getting into surgery and medical research, what inspired you to pursue this? Has it lived up to your expectation?
What inspired me to pursue surgery? So I always wanted to be in a field that had the most immediate impact on my patients. We go to the operating room, we operate on somebody for 2 or 3 hours, they come out, they're completely cured. And for me, that is a very satisfying outcome. And it's built on years and years of technical training, which I also enjoyed the challenge of that training, and I enjoy the continued practice of this. I was actually in the field of computer science before I went to medical school and before I became a surgeon. And one of the things that I was looking for was a career that I would train in the art of my practice, and I would want to do that for forever, no matter what level of leadership I achieved, no matter what level of career development I achieved, no matter what my role was in the medical field, I would still go to the operating room on a regular basis because I would still enjoy it. And I would still want to do those things that directly impacted the people that I take care of. And I still feel that way. I finished my surgical residency in 2004. So I've been doing this for a little while, and I've never grown bored of the operating room. I've never grown tired of the ability to really meaningfully transform somebody's life in just a matter of a few hours. And I've never lost respect for the privilege that our patients give us to do something that invasive to them, and the confidence that they have in us that we'll do our best to try to help their situation.
Thank you so much, Dr. Segev, for that wonderful, wonderful talk, and what an amazing way to end our Q&A session. I wish we could go on, however, we are reaching the end, and on behalf of everyone on Clubhouse, we are incredibly grateful for the work that you do and for the wonderful presentation that you give. Thank you so much, and it was an amazing pleasure to have you here on MedNews. I cannot wait to rewatch this session along with the others. Thank you to all of our panel members and attendees from all different platforms for your participation and question. If you missed this lecture, fret not. You can replay it here on Clubhouse or on YouTube as well. I would like to pass the mic to Dr. Yan for any final thoughts.
Thank you so much to Dr. Segev for taking time out of your busy day to devote to educating our community. We can't thank you enough for this. And of course, thank you so much to the great team that helps to put on these events and make them the success that they are. And of course, thank you to the weekly attendees that come to our platform each and every week. Thank you so much.
Great, thank you. Be safe out there, everyone.